I'd like to welcome you all to our 13th annual Michael A. Creedon Lecture on Aging. This morning, our speaker is Dr. Barbara Weinstein. Dr. Weinstein is a leader in the field of geriatric audiology, having developed one of the world's most widely used tools to identify patients with hearing loss. She's a recognized opinion leader in the field of audiology and has represented the field on federal panels and has led in a number of different professional societies. She has long advocated for the integration of hearing health care into mainstream medical care. She is committed to promoting the import of interdisciplinary management of older adults with hearing loss, as she firmly believes that the ability to hear and communicate is critical to delivery of person-centered care. And without further ado, I will give her the floor.
Great introduction. I like that. I'm going to use that. Thank you. that kind of covers all that I'll be discussing today, and I think you'll find that being an opinion leader means that I'm not quiet about sharing my opinions. So you'll hear a lot of my opinions, but they're all evidence-based. So and you can quote me on that. So I thought I'd start by talking a little bit about the field of audiology, who I am, the demographics of aging and hearing loss. I'm going to focus a little bit on communication because, in my view, communication is critical to delivery of healthcare. Disability posed by hearing loss, especially with emphasis on dementia, and then I'll talk about some of the benefits of hearing-related interventions for people with dementia. So, and I'll shine lights on factors that I think are kind of critical to the work that all of you do. So I know the audiology people here know what an audiologist is, but I'm not sure that everybody else knows what an audiologist is. But just to put it out there, we're primary healthcare professionals responsible for identifying people with hearing loss, diagnosing hearing loss, and people diagnosing people with vestibular problems. But in my mind, our biggest responsibility is to help people with hearing loss self-manage their hearing problems in all settings. Most audiologists today have a doctoral degree, but in the old days, most of us had master's degrees. Academics had master's degrees and PhDs. Work settings all over, private practice, ENT, rehab settings, university settings, and most states require audiologists to be licensed to practice. Audiology is kind of, we've been operating in a silo, and we've kind of kept a lot of the work on hearing loss to ourselves. But finally, the cat's out of the bag, and hearing loss has been identified as a public health problem. And as a public health problem, we need a large network of shareholders to help us work and help people with hearing loss function in society. So I have a public health approach to hearing loss, as I know Elton does, and essentially in order for an individual with hearing loss to really function, the society has to be set up so that organizations are tuned in, community networks are available, and public policy prioritizes hearing loss. So this is going to be more of a public health presentation than probably most audiologists are used to, but people in this end probably are kind of familiar with that approach. So the reason why it's a public health problem is because hearing affects all aspects of people's lives. So it affects work, it affects travel, it affects social life, home, safety, and primarily, for your purposes, healthcare settings. It affects transitions in care, it affects rehabilitation, work with PT and OT, primary care, and it really affects the intakes that you do when you're assessing somebody, an older adult. So my bias dovetails with the directions that the National Academy proposes for us to take in terms of working with geriatric. We need to develop new models of care delivery, and interprofessional care is critical, and that's why this is such a beautiful school, because of the emphasis on interprofessional, patient or person-centered care is a priority. We need to augment and strengthen the workforce with competency in geriatrics, and you guys, that's one of the missions here. Critical is fostering and promoting social engagement for older adults, because social engagement is key. It's kind of helps minimize many of the negative outcomes associated with aging. And my bias is that hearing is critical to social engagement, and that's something that audiology and must understand, that what the work that we do is to get people, to help people remain engaged and communicative, because that's critical to morbidity, mortality, and cognitive health. And then, of course, hearing, the delivery of care to persons in advanced stages of life, especially at the end of life, is also an increasing priority. And again, here we have hearing critical at the end stages of life. The last 2 years of life, recent research by Wolhagen has shown that people prioritize the importance of hearing and communication at that stage of life. So everything that I'm going to be saying, it reflects this bias. Patient-centered care, critical. Team-based care, critical. And critical to all that will be communication. So just quickly, you're all aware of the fact that the population is aging. By 2060, 2040, by 2060, 24% of the population will be over 65 years of age. That has significant implications in terms of how we work with people who are older. Life expectancy data are kind of interesting. The average 65-year-old today can expect to live another 18 years. If you make it to 75, your life expectancy will increase to 86. Most people who are going to be who are in their 80s will have a hearing loss, and you'll need to know how to communicate with them. Interestingly, women have a longer life expectancy than men, but they are spent, so that's the good news for the women. The bad news is that they're spending more of their golden years with disabilities. And so that women spend an estimated 30% of their remaining years with a disability, and men spend 19 to 22. So there is an advantage to being a man. Just kidding. Okay, so the oldest old. The oldest old population is an interesting population. That's the fastest growing segment of the population, I'm sure you're aware. By the population of 80 to 100-year-olds will double over the next 40 years. Interestingly, in that population, 40 to 50% will have dementia, 80 to 100 will have hearing loss. And the rate of change in hearing is even greater in people as they get to the old period of their lives. Hearing loss, as probably the audiologists are aware, is the 15th leading cause of global burden of disease, and it's the second leading cause of years living with disability globally. So it's been recognized, and it is a big deal. 2/3 of individuals 70 years of age and older have a hearing loss in both ears. Interestingly, only 1 in 5 adults over 80, only 1 in 5 adults over 80 has normal hearing. And however, despite the high prevalence, most people with hearing loss do not have any kind of intervention or amplification to help them hear better. So while most people who wear hearing aids are older, most people who are older and have hearing loss do not use hearing aids, which is the primary healthcare intervention. That's an important point here, because that means that a lot of the people that you're going to be working with will not have the ability, may not have the ability to understand everything you're saying because they're undertreated. And this just shows you the pyramid of the change in hearing, change in prevalence of hearing loss with increasing age, and change in prevalence of hearing aid use with increasing age. It's not very impressive in terms of the statistics, in terms of hearing aid uptake. So what we know is that age-related hearing loss is undertreated and under-recognized. 85% of older adults with hearing loss have not had their hearing screened. 22% only 22% have talked to their physicians about hearing loss. And what's important, and we'll talk about later, is that majority of persons with age-related hearing loss do not use any form of hearing assistance. This is an interesting statistic. This just came out from Kylie. Older adults are predicted to live more than half of their remaining years with at least mild levels of hearing loss. With more than half of remaining life lived with moderate hearing loss among people who are 75 years of age and older. So expect that hearing loss will be the rule rather than the exception. Okay, so why does that matter? What does it matter? Why should you care about communication and hearing? Okay, so person-centered care is a focus of delivery of geriatric care, and nothing about me without me is important, but it's hard to be there if you can't communicate. So communication difficulties affect physician-patient communication, healthcare provider communication, adherence, healthcare burden, healthcare expenditures, and I'll go into that a little bit more depth. But first I wanted to talk a little bit about communication, and that's the ability to be understood and to understand others. So it's the cornerstone of healthcare delivery. Communication is a kind of a loop. And what happens is that oftentimes healthcare professionals forget to close that loop. And that's problematic. So here we have a schematic of all the components of communication. You have the sender, you have the signal being encoded so that it can be transmitted. There's interference between the transmission and the reception. That's noise. That's our enemy. That's the enemy of hearing impaired people. And then the signal is decoded and sent to the person, the receiver. But what has to happen is that the receiver has to confirm back to the sender that they understood the message. So that feedback loop is often not closed. And that's something that we have to worry about. And that's why teach-back is a very essential and important part of delivery of healthcare, I think, for older adults. Okay, so and the noise piece being the enemy, these are some of the things you have to consider, or the environments that contribute to stress when you're communicating with elderly. So, and the acronym is NUTS. Novel. In a novel environment, it's going to be problematic. That's oftentimes in a healthcare setting. Unpredictable environment, sometimes the patients are not going to be able to understand what is being said. Threat to a self, if you're a vulnerable person and you're learning that that you're being diagnosed with a serious condition, that's going to be a threat to self. And a sense of a lack of a self-control and self-efficacy, these are going to all interfere with communication, so that you have to be aware of that when you're communicating with the elderly. The consequences of miscommunication, the consequences of not closing that feedback loop. The sender may, and the reasons for it. So one reason why there may be miscommunication is the sender may underestimate the needs or abilities of the recipient, or they may overestimate their own effectiveness. Probably none of us would end up doing that. Recipient may misinterpret or fail to provide feedback confirming their understanding of the content of the message. Interestingly, as I'm sure you're all aware, 40 to 80% of medical information patients receive tends to be forgotten immediately. Nearly half of the information discussed is incorrectly retained. And then add to that, a great deal is misunderstood because of communication difficulties. And these are the great mishearings that Oliver Sacks wrote about probably about a month or two before he passed away in the New York Times. These are some of his mishearings that he recorded. All or noneness rather than oral numbness, pontylitis rather than tonsillitis, and a biography of cancer rather than a biography of canter. So misunderstandings are predictable from the hearing loss, and these are what he recorded in one of his last articles in the Times. So I'm proposing universal precautions in healthcare settings. And these are the kinds of things that healthcare professionals should focus on. Do speak slowly. Do reduce extraneous noises. Do face the patient. Make sure the patient is wearing hearing aids if they have them. Use a portable communication aid if they don't have hearing aids. And give patient a written summary of the results of the encounter. Don't shout. Don't speak in the patient's ear. Don't speak to the caregiver instead of the patient, and don't exaggerate or enunciate your words. So these are just typical things, for example, when we go into a setting and we wash our hands, these, in my view, are in universal communication precautions that we should be focusing on. So the challenge to primary care related to hearing and communication. Hearing loss is prevalent among people with multimorbidity. So individuals will have two or more chronic conditions, most likely they'll probably have a hearing loss as well. And medical management requires person-oriented management and effective communication because of all the instructions that have to be delivered. And the burden of multimorbidity is that it requires multiple interactions with the healthcare settings, and the ability to communicate and carry out and adhere is essential. Interestingly, the non-audiology people may not be aware of this, but according to mixed work, lower ratings of patient healthcare provider communication and overall health. So people with hearing loss rate communication with healthcare providers more poorly than those without hearing loss. People with hearing loss have greater difficulty in engaging in discussions with their physicians, especially in noisy environments and with unfamiliar medical terms. That has to do with health literacy, with hearing loss interacting with health literacy. And hearing loss is independently associated with increased healthcare use, hospitalizations, and poor self-rated health over the past 12 months. In addition, what we know from the work of Kripalani is that following hospital discharge, 49% of hospitalized patients experience at least one medical error in medication, continuity, diagnostic workup, or follow-up. And 19 to 23% suffer an adverse event. And the researchers suggest that most of these errors are due to communication breakdowns. Hearing is not usually considered part of communication, so they didn't point to hearing, but they identified communication as probably one of the variables leading to these adverse events. And according to Pandy, hearing aid users and non-hearing aid users have different experiences in terms of access to hearing healthcare. And this is just the population that was studied, how they defined people who were hard of hearing. And what they were looking at, so people's hearing was not measured, it was self-reported. And basically what they were looking at, whether or not hearing aid use impacted the difficulties in obtaining health care and satisfaction with access to health care. And what they found is that the hard of hearing were likely to report experiencing more difficulty and delays in accessing health care. The disparity persisted even after controlling for significant variables like depression, which is known to affect access. And there was no difference between the groups, however, in terms of satisfaction. But access is impacted by the ability to hear. Persons with age-related hearing loss, this is according to McCullough, avoid contact with healthcare professionals because of communication difficulties. They're more likely to use mental health services than those without hearing loss, and are more likely to experience unmet healthcare needs. So on the audiologist side, we've got to make sure that our patients are more proactive about talking about their hearing problem to the healthcare profession, and we have to help them self-manage so that they can advocate for themselves in healthcare settings. And then on the non-audiology side, you have to be aware of this and try to make sure you practice some of those universal precautions. So there's significant comorbidity associated with hearing loss, and poor access is compounded by known communication difficulties. So sources, what are some of the sources of the miscommunications in a healthcare setting? And interestingly, there's a psychological component, and most of you can probably identify with this. If you have to put a lot of effort and concentration and focus into trying to understand what somebody is saying, for example, today, and if there's not a lot of reward on your part, then you're probably going to kind of step back and not really pay attention. So it makes sense if older people cannot understand the person with whom they're communicating with because it takes so much effort, then they may just, so that they may just kind of withdraw and not pay attention. So And what we know is that when people who are older have difficulty self-managing and tend to withdraw, this leads to stress and physical health problems, like the effect of stress from not being able to communicate affects systolic levels. And so there are physical health problems associated with the inability to self-manage hearing loss in different settings. Audiologists, our responsibility is not only to fit hearing aids, but to help people self-manage the hearing in all the different situations in which they encounter, because it has many physical implications, which we'll talk about. Just a little aside, we just finished a systematic review. It's going to be published in JAGS within the next month, and apparently they're going to give it a lot of press. And what we did was we looked at 67, we did a systematic review of all the articles on physician-patient communication, and we wanted to see where, when, or how often hearing was mentioned in these articles on communication in healthcare settings. And interestingly, 75% of the papers did not mention hearing loss at all when they were talking about communication in healthcare. 24% or 16 studies did mention hearing loss. And this is kind of the breakdown in terms of from mentioning to using an intervention to help people hear. So just quickly, for example, 6 of the articles of the 67 mention hearing loss as a factor in communication in the introduction, but they didn't tie hearing loss to any of the findings about poor communication. In only 3 of the studies, hearing loss was an exclusion criteria when they're looking at how people communicate in healthcare settings. The distribution of hearing loss in the sample was reported in only 2 of the studies, and there was no analysis of the outcome. So hearing loss is underrepresented, undertreated, and underreported. That's another thing we can talk about, especially in the literature. So let's now move on to hearing loss and the different comorbidities. So I think we're all familiar here with the International Classification of Functioning, Disability, and Health Framework. And essentially, what this suggests is that the outcomes, or how you cope with the health condition, is impacted by environmental and personal factors, and these are intertwined and determine whether or not people are going to have activity limitations and participation restrictions. So it's not only the existence of an impairment, but it's the interaction of the person's personal variables, the environmental factors that will impact how the individual functions. And this is just a little summary from Lambert on the impacts of hearing from the ICF, using the ICF formula or classification system. So the personal factors that we know affect how a hearing loss will impact an individual: socioeconomic status and hearing health literacy, education, and the ability to coping mechanisms and resilience. We were talking about, Elton and I were talking on the way in, and these are personal factors which are important in terms of whether or not a hearing loss is going to impact somebody. Limitations into the environmental factors, attitudes of others and attitudes of the patient. The availability of support system is very critical to how an older adult will self-manage the hearing loss. And from a recent study by Singh, we know that the most important variable that impacts satisfaction with hearing aids, for example, is the availability of support networks. And people with mild hearing loss are more likely to take up hearing aids if they have a support person with them at the hearing healthcare encounter. So the availability of support system and relationships is important. Some of the body functions impacted by hearing loss: cognitive, which we're going to talk about, musculoskeletal function, mobility, self-care, all impacted by hearing loss. And we know that the participation restrictions resulting will be social engagement, relationships, and of course communication. So hearing has broad impacts, and this kind of summarizes some of the different areas: utilization of health services, loneliness, dementia, falls, frailty, mortality. It's all over the place. It's just now recently that Frank Lin from Hopkins has mined every single database around and uncovered all these different impacts of hearing loss. The big question is, what can we do about it? So it's interesting. This was a study that just came out by Judy Dubno. And what she looked at was kind of contributing factors to the fact that when you look at the test results that we administer, when you test somebody's hearing, everybody tests the hearing and you get an audiogram, a graph of their hearing. And most audiologists just look at that audiogram and they think the audiogram tells all. But in actuality, the audiogram doesn't tell much. And what she was looking at was to see, why is it there are people who have such significant self-reported problems, but the audiogram doesn't tell you that, and nor do the speech understanding difficulties. What she found and has been reported many times is that if the person is experiencing frustration, embarrassment, if they're uncomfortable, if they're anxious in a lot of communication settings, that's going to affect their ability to communicate and their ability to understand. So the self-report of how the patient is feeling, which is my area of interest and expertise, is kind of critical to even how people are going to be able to function in the real world. So self-assessed limitations and participation restrictions will impact the ability to understand speech and noise because of the impact on cognitive function and working memory and executive function. So interestingly, most of us think of the ear as just the ear, but the brain, as we'll see later, and cognition is critical. There's a whole, they're all intertwined. And these are some of the situations that cause people to have this difficulty. They're associated with extreme difficulty understanding speech in a noisy situation because of the interaction between the psychological and the cognitive. If they have difficulty, if they're frustrated when talking to family members, if they're embarrassed, if they feel uncomfortable, this is going to add extra stress. So, but we can assess that. We should be assessing it routinely because this self-report and the hearing handicap inventory, which is what this was based on, is used for screening people for hearing, to uncover some of the disabilities that they have. So it's important to understand how the hearing loss is affecting the patient from the patient's perspective because it tells so much. So now what I want to do is move on to hearing status and dementia. And I was going to talk a little bit about dementia and the vestibular system, but I'm not going to because I don't have time. But know that hearing loss, vestibular system, and dementia are all intertwined. So I'm going to just talk about hearing and dementia because of time frame. So this is I've adapted my definition of hearing loss, but I'll first give you the definition of dementia that I found in my reading, and then you'll see what you make of the definition of dementia and the definition of hearing loss. Dementia is a major neurocognitive disorder. It interferes with cognitive function. It interferes with communication. It interferes with performing everyday activities. There's impaired processing of emotions, of music, and nonverbal emotion. I have a more. I'll drill down further, but that's kind of a very comprehensive, holistic definition. Here's a holistic definition that I came up with hearing loss in elderly people, age-related hearing loss. It's an auditory cognitive-based condition which interferes with communication, cognitive function, performing activities of daily living, understanding the emotionality of communication, and also it interferes with understanding and appreciating music. And then you have vestibular, which I'm not going to go into. Okay, so hearing starts here at the ear, but every step along the way from in the brainstem all the way up to the brain is critical in terms of the ability to process sound. So processing, here we have at the cochlea, you have sound detection, and then we have perception, and then we have attention and understanding, which are critical. So again, this is also a loop, and the brain is probably more important in terms of understanding and communication, or as important in terms of communication as the periphery. So when in terms of just to give you an appreciation of what happens with the hearing loss and why it interferes with the ability to communicate, when a signal of which is poor fidelity, that would be a hearing, if somebody has a hearing loss, is transmitted from the ear to the brain, it requires considerable more effort on the part of the person with hearing loss to process the signal. And the increased demands on the individual in terms of the effort required to communicate is going to impact the ability to process information, and it's also going to impact the ability to remember information. So people who have a hearing loss, because of all the effort and the cognitive and the mental effort and the cognitive load that it creates, people with hearing loss, oftentimes, not only are they not hearing things, so they're not going to be able to remember it, but the reserves are not going to be available for people to even store information in their memory so that they can recall it. And what's interesting is that prolonged activation or understimulation of the temporal lobe from lack of input from the periphery is going to lead to permanent changes in the brain. So there is neuroplasticity in the brain, and that works for and against people with hearing loss, and we would argue that stimulating from the periphery is going to help in terms of maintaining the neuroplasticity as an advantage. In terms of dementia, we also have the same thing with cognitive effort. Cognitive impairment along with age-related hearing loss will affect an individual ability to communicate even more because of the effort that people with cognitive problems have in terms of being able to attend and focus, and also because of the difficulty that people with hearing loss. So it's a kind of a double whammy. So older adults with cognitive impairment or dementia are doubly challenged when trying to communicate because of the impaired encoding at the cochlea and decoding at the level of the brain. Another definition of dementia, it's a highly diverse disease. There's a lot of individual variability, as you're all aware. The prevalence is on the rise. Interesting risk factors: low involvement in leisure activities, sedentary state, diabetes, hypertension. There are a number of different risk factors, but I'm just identifying the ones that might be related to hearing. And what people are looking for are interventions that could delay the onset by 1 year, to help kind of save money and also to reduce the global prevalence, more importantly. So it's a syndrome, as you know, and multiple domains of cognitive function are affected. What's most important is that it's going to interfere with levels of functioning and performing activities. So one of the first symptoms that often appears when people are faced with dementia are communication problems. So there's difficulty, some typical signs of dementia, early communication signs of dementia: difficulty in finding or pronouncing the right words, losing the thread of a sentence, tending to repeat words or questions, struggling to follow television or radio. The person may become quiet and withdrawn. Very animated, they might appear inappropriately animated, and they could have, of course, emotional side effects and depression, anxiety, irritability. Interestingly, participation in more than 6 leisure activities, there's a 38% lower risk of developing dementia, and that's important in terms of the hearing and the engagement in social activities. Now, which is this? This is Miss Smith. Am I describing Mrs. Smith as somebody with a hearing loss, or am I describing Mrs. Smith as somebody with dementia? She has to work hard to follow what others are saying, especially in noisy environments, at a party, at an office gathering. Her cognitive energy is focused on trying to decipher what has been said. She's introduced to someone whose name she does not know. She's asked again what is the person's name, and she still does not quite get it. Dementia, hearing loss. The conversation goes on from there, and within a couple of minutes, she's lost track of the subjects. She's guessing at responses, making non-committal replies, nodding and smiling as if she's understood. hearing loss or dementia. And when she walks away, she has no idea about what the people were saying, hearing loss or dementia. So hearing loss and dementia, there's a lot of overlap in terms of the presenting symptoms. So hearing loss and dementia are more prevalent in people over 65 years of age. Hearing loss and dementia compromise social engagement, cause difficulty remembering new information. There's changes in moods and personality, withdrawal, social withdrawal. So there's a lot of overlap between dementia and hearing loss. And there's also individual variability, of course, in dementia and in hearing loss. How one reacts and how one functions is going to be considerable variability. Hearing clearly leaves greater cognitive hearing. If somebody can hear, that's going to leave greater cognitive reserve for remembering, responding, analyzing, and even thinking. So if we can improve the audibility of a signal, that's going to help free up some of the cognitive reserve that's needed for processing information. So that applies even to somebody with dementia who has to use so much cognitive effort to try to function, especially in mild dementia. By making a signal more audible, not necessarily, and hearing aids are not the only solution, this could be very, very helpful, and we'll see how. So I think I've mentioned this, but when exerting considerable listening effort, the hearing impaired individuals report difficulties in challenging listening situations over which they have little control. And this sustained listening effort with low reward leads to fatigue, and it can be very troublesome. So the fatigue is another issue in terms of hearing loss. What we know from the research is that people with self-reported hearing difficulties, we don't know this from the audiogram, but the self-reported hearing problems on the hearing handicap scale are associated with considerable fatigue as well. And that is, again, leads to withdrawal. So, and this relates to dementia and hearing loss. Fatigue is a control mechanism. Interestingly, fatigue is a kind of protective. It's a control mechanism to limit the investment of resources in an unrewarding activity for which the individual has no control. So the fatigue is going to protect you by withdrawing. You're not going to have to challenge your reserves. And sustained listening effort, which is something which audiologists are looking at a little more and more in terms of the impacts of a hearing loss and the benefits of what we do. Sustained listening effort is a precursor to fatigue. So we have to worry about that, and hearing can't help. So now the direction of the relationship. Hearing loss, does hearing loss lead to dementia, or does dementia lead to hearing loss? Anybody have any thoughts about that? Is it bidirectional?
So a question I have, in these individuals with dementia, the hearing loss, is it peripheral hearing loss or is it central hearing loss? And are you able to delineate between the two?
We can identify the peripheral hearing loss from the audiogram.
Okay.
We're not as good at identifying the central loss, but we do measure both, and it's both. Okay. It's auditory, and it's peripheral, and it's central, and it's a combination.
Okay.
Yeah. So,
I just have a question because I'm not familiar. Is this mostly sensory neural hearing loss, or is also conductive?
So the old age-related hearing loss is inner ear central. The peripheral is a sensory neural hearing loss. So sensory neural hearing loss, meaning that's the inner ear primarily and the nerve, and the treatment for that is typically, there's no medical treatment. It would be hearing assistance, for example, hearing aids, cochlear implant, depending upon the severity, and hearing assistive technologies. So what we know from the Baltimore longitudinal study by Frank Lin is that baseline hearing loss increases the risk for incident dementia. There's an increased risk of incident dementia with baseline hearing loss, which is associated with changes with hearing loss severity. And this is from the Baltimore longitudinal study. I want to get this. Hearing loss is independently associated with incident all-cause dementia. More than 1/3 of the risk of dementia is associated with hearing loss. That's when controlling for variables that might come into play. And what we know is that adults with mild hearing loss are 2 times more likely to develop dementia, adults with moderate sensory neural hearing loss 3 times, and adults with severe hearing loss actually 5 times more likely to develop sensory neural hearing loss. We have a question over there. And then I'm going to move along.
Is this an associative connection or a causal
We don't know
connection?
about causality. It's not causality yet. But there are some theories which I'll share with you. And this was another epidemiological study by Fisher. And he looked at multiple sensory impairments. So they looked at vision, they looked at olfactory, and they looked at hearing. And what they found is that 56%, and in their study, 56% of their participants had multiple sensory impairments. Most of the people in the study had hearing loss. Interestingly, and this was a longitudinal study, participants with sensory impairment at baseline had higher incidence rates of cognitive impairment than those without sensory impairment, which is probably not surprising. And here we have the 10-year unadjusted cumulative incidence of cognitive impairment. 17% developed, in participants with hearing impairment developed the cognitive impairment, and then olfactory, 30%. And we know that a change in olfactory sense is one of the earliest signs of dementia. So when my husband first started not being able to smell anything, I did put the fear of God in him, but he's okay now. He's still okay. And he's happy that he can't smell a lot of things that he can't smell. So what's interesting is that an individual with hearing, visual, and olfactory impairment have a higher risk of developing cognitive impairment, 15 times that of an individual without. So sensory impairments, multiple sensory impairments, are pretty significant in terms of the predictive value of developing some sort of cognitive impairment. Highest positive predictive value for cognitive impairment was having all 3 impairments. So the study was, can we do sensory screening to screen people for cognitive impairment, which is kind of an interesting study. So I'm going to skip that. Now looking at dementia, so is evidence that people with a hearing loss are at increased risk for dementia. Now let's look at the other way, people with dementia and risk for hearing loss. And this is a study, this was not on dementia, but this was a study of cognitive health and hearing out of Australia. And what the mini-mental status was one of the cognitive measures that they used. And what they wanted to look at was predictors of change over 11 years in terms of hearing loss in this population. And what they found is that predictors of hearing loss after 11 years, the only significant predictor of rate of change in hearing was probable cognitive impairment, and faster increases in hearing were observed. Faster increases in hearing down over an 11-year period were associated with probable cognitive impairment, and this was highly prevalent in older adults and in women. So what they concluded is that after adjusting for socio-demographic and health variables, probable cognitive impairment at baseline was associated with poorer hearing loss down the pike. So incident probable cognitive impairment was associated with poorer hearing, especially in the higher frequencies, which is kind of an interesting study. So there's a little bit of both. It might go both ways. But again, this is not a causal effect. And why the possible relationship? There's a number of theories, and there's probably all these intermediate factors that are coming into play, and we don't know the answer yet. But hearing impairment, whether or not it's going to be associated with cognitive decline, it could be because of the increased cognitive load, changes in structure and function of the brain, social isolation, or common etiology. So these are the different theories. A cascade model, hearing loss is associated with sensory deprivation, social isolation, lack of stimulation can be the factor that leads to cognitive decline. These are all speculation, and these are the different theories, which I'm not going to go into. So the hearing aids make a difference. What do we know about hearing aids and cognition? A lot of the hearing aid manufacturers are putting out literature that says, go to the audiologist because hearing aids cure the dementia. That's just not the case. It's a marketing ploy, and audiologists have to have an answer to that question. And I think I think that the answer is here. There's no direct effect of hearing aid use on cognitive decline. No direct, based on the literature. There are 2 or 3 studies that have come out with this. That's hearing aid use. Cochlear implant use is a different thing. We found that cochlear implants do impact cognitive function and dementia. That's a different conversation. There's no direct effect of hearing aid use on cognitive decline, but depressive symptoms and social isolation may mediate the association between hearing loss and dementia. So there's no direct effect, but depressive symptoms and social isolation may mediate the relationship. Here's what audiologists should tell a patient, and what you should know, I think, when you're referring patients for a hearing test. By partially restoring communication abilities. So when we give somebody a hearing assistance, like a assistive technology or a hearing aid, what we're doing is we're restoring their communication so that that may improve their mood, which we know hearing aids do, increase their social interactions, and then this may enable them to participate in more socially stimulating environments. So it's kind of that we need to boost engagement, because social engagement is protective against cognitive decline, and hearing assistance may be one of the ways to do that. So that, to me, that's a logical rationale. And I just did publish a study, which I'm not going to talk about, on the relationship between hearing aid use and social and emotional loneliness, and we did find that hearing aids do reduce the social disengagement or loneliness that people who are older experience. So here's another study that was done by MAMO. It just came out. They looked at whether or not hearing assistance technologies, so not hearing aids, they looked at whether hearing assistance technologies reduce the communication difficulties associated with dementia. And they recruited individuals from the Johns Hopkins Memory Center. These people had mild to moderate hearing loss, and they were diagnosed with dementia. They had neuropsych test battery, depression, a neuropsychiatric symptoms questionnaire, and then they also looked at caregiver burden. The participants had a choice. They could choose between 1 or 2 different types of inexpensive, commercially available hearing assistance. And they used community workers for this. They didn't use audiologists. So what the patients were able to get was a pocket talker, which is a personal amplifier, which is wonderful in one-on-one situations. There's a headset that people wear, and then you have the controls. It could be wired or wireless, and basically you just turn the volume up and you hook the person up, and the person can hear you amazingly well. Commercially available out on Amazon. The pocket talkers are very, very wonderful way of improving audibility. Not that people necessarily are going to use it on their everyday lives, but in a healthcare setting or at the end of life, they're wonderful. Or the Sound World Solutions, this is called a personal sound amplifier. This is something that you buy over the counter. It's Bluetooth enabled. You can talk on the telephone with the Bluetooth, and it amplifies sound. This is it's a personal sound amplifier, but there's also one available as a hearing aid. Again, commercially available, inexpensive. So what he was looking at was hearing aids are. The claim is that they're not affordable, they're inaccessible. So he wanted to test the proposition that if you give people with dementia inexpensive devices and 2 hours of rehab, what's the impact? And here again, here's the personal hearing assist, the pocket talker. And they had 2-hour sessions on hearing loss, and the sessions were with the caregiver and the person with dementia, and they talked about how to use the technology. They gave them communication strategies. And they talked about how to function how to self-manage. And they did pre and post measures of the baseline measures. Interestingly, first finding was that older adults with dementia had the poorest scores. Older adults with dementia who had the poorest scores at baseline ended up showing the greatest improvement in their behavior. So the people who were worse off beginning did a lot better. the caregivers reported that there was at least some benefit from the program. So 90% of the caregivers said that there were good outcomes in terms of more qualitative than quantitative. The caregivers reported that the training session was useful, and they thought that others would benefit from the program. Here are the qualitative improvements that they reported in communication. This is the caregiver's report. The stories that the family member who had dementia were telling were retold more accurately. The questions were posed that they asked were in smoother sentences, so communication was a little bit better. The people with dementia had a stronger willingness to make decisions, and the decisions made more sense. They spoke louder, asked more questions, followed the conversation. They connected with life in a renewed way, was another qualitative outcome. And social engagement improved their listening to music. So these are kind of interesting qualitative outcomes. So by maintaining an active and engaged, I'm not going to go. So these are just some communication difficulties that you should look out for when you're doing an intake on people with dementia or hearing loss. I just want to give you a couple of tips on how to communicate and when you're working with people with dementia based on some of the data that we have. These are some of the things that you should behaviors you should look at. Losing the thread of a sentence or conversation, repeating words or questions. This can be typical of people with dementia. This is more for like the audiology people, because most of the other people here probably use it. Response time. Oftentimes people with dementia will show a little bit or with mild cognitive impairment will show a little bit of a slower response time. Limited vocabulary being used. The caregiver is often responding rather than the patient. And the reason why I'm bringing this to the attention of the audiologist is because now more and more people are saying that audiologists could help on identifying people who may be at risk for cognitive decline, because we have long-term relationships with our patients, and if we can look out for this, you might be able to get people in earlier to help make decisions if they have dementia. This is from the people that I work with at one of the Alzheimer's associations. Additional behaviors to probe for. Is there a lack of reaction to sound? Is there difficulty understanding the emotional tonality in a person's voice, anger, or when they're upset? And then music appreciation, that's another area. So in my view, and it's not necessarily doable, hearing function should be assessed in all patients who have a diagnosis of dementia. It can help identify a factor that may be detracting from the quality of their life, and we may be able to address this condition. You should be implementing procedures for reducing the impact of hearing loss on behavior. For example, face-to-face seating in a quiet room, removing noise, personal amplification, sound field amplification. For example, if there's a counseling session, group counseling sessions going on. The sound field amplification is very, very helpful. Treatment options. Sometimes just removal of wax can make a difference. Hearing technologies, environmental modifications, as I said, sound field FMs, to reduce cognitive load and listening effort on people with dementia. Even if they don't even have a hearing loss, just the ability to hear a signal better will make a difference. Communication strategies should be used, interdisciplinary collaboration, and try to disambiguate the effects of peripheral from auditory cognitive, which is often hard to do. So these are just some tips for how to communicate. Help orient the patient, explain why you're doing what you're doing, so that you recognize and understand the person's feeling. You want to try to use reassuring words when you're speaking to them. Avoid making situations worse, and focus on self-efficacy. Focus on what the people can do well, rather than what is challenging to them. So you want to focus on especially that first. Try to address the patient directly. Gain the person's attention first, of course. You want to speak distinctly at a natural rate. It's also important, of course, to have a family member present when you're communicating with them. So in terms of communication strategies and environmental changes, again, this is kind of a public health model. Minimize background noise, and this could be one of those universal precautions things. Use face-to-face communication. Rehearse a misheard statement rather than just repeating it, and summarize components of a statement rather than simply stating "huh." So these are just ways that we, the communicator, can modify our communication. So hearing loss is a social sense, and the single biggest problem in communication is the illusion that it has taken place. That's the lack of the feedback loop. So this is Meryl Streep on aging. You have to embrace getting older. Life is precious. And when you have lost a lot of people, you realize each day is a gift. And Einstein, do not grow old. No matter how long you live, never cease to stand like curious children before the great mystery in which we were born. So just some food for thought. Dr. Goldstein, you might appreciate this. And just want to hope I shed light on some of the areas that are near and dear to me. Thank you.
Thank you very much. Okay. Oh, we have one right here.
It makes sense that if someone with dementia can hear more clearly, that could make their life more bearable.
More clearly or more easily?
Okay, sure. But my question is, no, those would really be hard experiments to control, right? Meaning you can't really give someone a hearing aid that doesn't work as a negative control or something to be sure that it's not just, it looks like they're interacting better. I mean, I'm sure there's a huge component of both, what would you call it, placebo effect and all, but there's probably something real too.
Yeah. But we can do non-behavioral tests. And when there's brain imaging done, you could see the differential effects in the brain.
So with persons who have more advanced dementia, so somebody who's having that like word salad or they're nonverbal, is it too late to assess for hearing, or how do you assess for hearing?
So here's what I would say. First of all, it's going to be too late to give them hearing aids. That's just not the way to go. In terms of assessing hearing, it may not be worth the time. I would just say, just use a technology, use a pocket talker, and you'll see a difference immediately. I mean, I say, because you can be sure that they'll probably have some sort of a hearing loss, and you'll be sure. But what happens with this population, especially the ones who are more involved, is that many of them haven't heard sound in a long time, so it takes time to adjust to even that amplified sound with the amplifier. That's the route I would go.
Well, thank you all very much for attending. Thank you again, Dr. Weinstein, for this presentation.